Very good.
Oh, good afternoon, everybody, and thank you for joining me on this Friday afternoon. My name is Dr. Christopher Duma, and I'm a neurosurgeon affiliate of the Cell Surgical Network. What we're going to talk about today is one of probably the most exciting aspects of stem cell work today, and that's actually using stem cells directly injected into the brain. And this is something that we have kind of pioneered in the Cell Surgical Network. A little bit about myself. I'm a board-certified neurosurgeon. I practice in Newport Beach, California. I have some academic affiliations, and I specialize in brain tumor surgery and Parkinson's surgery, and the treatment of pain disorders like trigeminal neuralgia and functional disorders like normal pressure hydrocephalus. And I'm the co-director of the Parkinson's program here. I do the deep brain stimulation for Parkinson's disease as well. I am the head of the Gamma Knife radiosurgery program. And a long time ago, back in 1993, when I started my practice at Good Samaritan Hospital in Los Angeles, I became affiliated with a group there that was doing stem cell work in Parkinson's patients. They were actually injecting aborted fetuses' stem cells into the human brain by actually injecting them into the parenchyma of the brain. And we probably did about 60 to 70 patients this way while I was there, and the results were absolutely fantastic. The problem was that they were fetal tissue. It was became a little bit controversial at the time, and it fizzled out. To this day, however, I have patients that are out 25 years, 24 years from the injection of those stem cells in a very late-stage Parkinson's patient who are still doing quite well. So stem cells into the brain is something that I had been doing back then, always wanted to do again. And now, through these resources here with the Cell Surgical Network, I've been able to revisit this. So about 3 years ago, I ran into one of the other affiliates, and we discussed putting in stem cells intrathecal, meaning into the spinal canal, for neurologic conditions, multiple sclerosis, Alzheimer's disease, ALS, for example. And the concept to me was not a good one, because if you did it intrathecally, the stem cells have weight, and they probably don't make it down into the whole entire CSF circulation of the brain. In other words, you inject through a lumbar puncture, and the cells just by gravity will fall to the bottom of the spinal canal and really not get where you want them to be. So I remembered how we used to inject chemotherapy into the brain, and that was through a small little port that we put there. Some people know what a portacath is. If you have cancer and you don't want to use the IV source in an arm or another IV source, you can implant a portacath. Well, we can do the same thing in the brain. We can implant a reservoir that the tube of which goes into the lateral horn of the ventricle, and we can use that port over and over and over again to inject chemotherapy or anything else you want to inject into the brain. Been around for 40 years. And I said, what a great idea that would be to inject directly into the brain stem cells for patients with neurologic conditions. And that was the birth of this, this concept. And that was 3 years ago, and what I'm going to show you today is the results of our 3-year work in a total of 31 patients that have had intracerebroventricular, that's the word, intracerebroventricular, so not the intraventricular. Sometimes people think that's in the heart, but this is intracerebroventricular injection of stromal vascular fraction stem cells into the brain through an implanted Ommaya reservoir. What I'm going to show you is actually a elongated version of what I've presented at 2 major conferences already. So we have presented this data at two major conferences. One was last September at the Congress of Neurologic Surgeons meeting in San Diego. Podium presentation, plenary session, and it was extremely well received. I actually followed the group at Stanford who presented some of their work on stroke with stem cells. And then it was also presented in Memphis, Tennessee in October of last year, 2016, where I presented at the International Society for Cellular Therapy. And once again, that was a 20-minute plenary session splinter group that I presented all these data that you're going to see right now. And it, again, was very well received. So here we go. Basically, when I started this 3 years ago, there had been nothing in the literature about putting anything into the brain, especially intraventricular. And we've had, some anecdotal experience with intrathecal injections where, affiliates within the system have injected intrathecally. And I'm not saying it's the wrong route. I'm saying it's a route that can be used. But if we're looking for a global effect from the stem cells, perhaps this route that I'm going to describe today might be the best. And as you know, through the Cell Surgical Network, we've had thousands of affiliates and thousands of patients selected. In fact, Drs. Berman and Lander have already presented their safety papers to the FDA. The real question is if you inject any type of stem cell, if you inject an aliquot of stromal vascular fraction, which contains mesenchymal stem cells, or you somehow take stem cells out and inject those into the brain that are of a mesenchymal source, are they actually going to turn into neural stem cells? That's one big question. So are we just wasting our time injecting mesenchymal stem cells into the brain and they're not going to turn into neurons, or they're not going to help anything? Well, paper like this one, back as far back as 2010, and even before this, have proved that stem cells from a mesenchymal source can definitely differentiate into neural tissue. And we pray that the local environment, the environment that these stem cells are injected into, will guide their differentiation. And of course, this study that I started 3 years ago was basically a phase 1 study. We really weren't looking for utter, fantastic results in the patients clinically. What we were looking for was safety. Can we, on multiple occasions, re-inject through this port? Will it work? Are the patients going to get infections? Are they going to have complications? Are they going to grow a bone in their brain? Are they going to have a complication related to the treatment? And that's where we came up with the proposal to do patients that had absolutely no other options therapeutically or clinically for their diseases, and I'll get into that a little later. So yes, the answer is yes, that mesenchymal cells can actually de-differentiate or redifferentiate into neuronal cells. They not only have that factor, but they, as you know, have an anti-inflammatory effect, and a number of conditions, let's say Alzheimer's disease, multiple sclerosis, have an inflammatory component to them for sure. And perhaps that is the route that is taken by these, these diseases to destroy the human brain cell. So it was our hypothesis that if we put it into the ventricular system, if you know the circulation of the ventricles, all CSF starts in the ventricles and then it circulates around the brain. The next question was, would the cells, once they're injected into the ventricle, actually get into the parenchyma of the brain? So that we had to kind of figure out. And our IRB, when we proposed to them this study, they wanted to see some animal trial work. So we did such. So for about a year prior to our first patient, we studied, immunodeficient rats, and we injected human stromal vascular fraction into the rats. And this is how it's done, in case you guys don't know how to inject a rat stereotactically. There is a stereotactic device that you can put the rat's head in, and you can very precisely, using a map of their brain, inject into their ventricular system, kind of like what we do in humans. So the first test was to show that we were actually getting into the ventricle, and you can actually see the track right here where the needle is going into the lateral ventricle of the rat, and we're injecting tryptan blue, and you can see that the whole ventricular system, even the third ventricle and down to the skull base, is getting the tryptan blue. So we felt confident that we were getting this the cells into the ventricular system. And then we did various staining to look for any reactions, tumor formation, etc. On sacrificing the animals, the only thing we saw was a little bit of the hemosiderin products at the base of the skull, but there was no other blockage of spinal fluid. There was no hydrocephalus that occurred in the animals, etc. The brains, after we sacrificed the animals, looked exactly identical, whether they were injected with saline or whether they were injected with the stromal vascular fraction. And then we looked at the cytoarchitecture under the microscope, and there was no change in the cytoarchitecture of the two. One, the control studies of saline versus the SVF injected animals. We looked at Nissl staining to look whether there was any neuronal changes or loss or damage, and there was none. And then we looked at the various markers like CD105, which is very big in signaling a number of things. First of all, cellular migration, which tumor cells can have, cellular proliferation and cluster formation, etc. And the difference between the CD105 levels was there was no difference between the saline injected animals, so we felt safe about that. CD16, we look at the inflammatory response, and those are found on natural killer cells. So by injecting in these animals, were we getting a big immune response? And the answer was basically no. And then CD3, also looking for an inflammatory response, and the answer was no. So there was no difference between the two. Finally, we wanted to see whether the cells made it into the parenchyma of the brain. And as you can see, the cells that were injected intraventricular actually got into the parenchyma of the brain. This is the area that we actually targeted in the brain to look for these cells that were marked and stained with HMT, because we were injecting human cells. And so what you saw was here, injected cells into the ventricle getting into the parenchyma of the brain. So we were very happy to see that as well. And so from the animal work, we were able to conclude that, first of all, no CSF was blocked. There wasn't a detectable immune response. And it did not change the normal cytoarchitectonics of the animals. And the cells could definitely penetrate the ventricular wall. There was no excessive growth. There was no tumor formation. And the only thing we found was there was a little staining of the basal cisterns. So with this, the IRB allowed us to move forward for human study. And it really is rather simple to do this move, because in my practice of neurosurgery, patients bleed into their brains all the time. When I cover the emergency department, I see patients who have had brain hemorrhages, subarachnoid hemorrhages, intraventricular hemorrhages, all sorts of bleeding events in the brain. And they can do very, very well after that. So putting a blood product into the ventricle is not new to the field of neurosurgery, and it's certainly not new to me. So for me to inject through a reservoir a blood product was very simple. The IRB did approve us to do these various diseases, and as you can see, there's Parkinson's disease with its variants, ALS, traumatic brain injury is approved, multiple sclerosis, stroke, Alzheimer's disease, and spinal cord injury. These were the initial diseases that were approved. However, for me going forward to actually use this technology and use this technique, I only took the patients that had absolutely nothing else to offer. And I'll give you an example. ALS. ALS has a survival of about 3 to 4 years on average. There's one drug that is FDA approved to treat it, and it's ineffective of cure. Alzheimer's disease is a natural. Sure, we have a few drugs that actually help daily life or quality of life, but nothing that changes the longevity or the natural history of the disease, and nothing that has been shown to change the actual disease process itself. So later stage, maybe middle stage Alzheimer's patients, stage 3, stage 4 Alzheimer's, I'll get into that. The staging of Alzheimer's is like so. We look at Alzheimer's disease as a continuum of forgetfulness and cognitive impairment. And the patients that we've had in our series so far have all been around stage 3 or 4. Patients that are in the stage 6, where they're literally almost bedridden, family members and everybody doesn't even want to entertain the concept of doing anything more for them, and is just probably hoping for death. But the stage 3 and 4 patients are really the perfect subset to look at, and we'll go into that. Tau protein, you've probably heard of beta amyloid and tau. Well, tau protein is what's associated with the microtubules, and microtubules allow flow of information and chemicals through the axons. Well, what happens when tau is phosphorylated is the microtubules start breaking down, and they self-destruct. So phospho-tau turns out to be an end product, a side effect of the neuronal death. And so we look at things like total tau, the amount of tau, and the phospho-tau ratio, where phospho-tau is the bad tau. And then, of course, you know about beta amyloid. So beta amyloid is another, toxic oligomer that we actually see in patients with Alzheimer's disease. And I have to tell you that the normal brain has beta amyloid in it also, and can be found in large quantities actually. But that's why we give pause to whether beta amyloid is the cause or an effect of Alzheimer's disease. But we look at something called the ATI, the beta amyloid to total tau index, and then we can do some analyses. So what I'm leading to is that when we studied our Alzheimer's patients with CSF stromal vascular fraction, we tested their spinal fluid. And the way we test it is we send it to a lab. It's called Athena Labs. And we send it, and we're looking for the levels of phospho-tau. The higher the phospho-tau level, the more consistent their findings are with Alzheimer's disease. The higher the ATI index, the less consistent, and the lower the phospho-tau, the less consistent they are with Alzheimer's disease. So if you get your CSF analyzed by this lab, you want your asterisk to be in this box. If your asterisk is in this box, you'd rather it be over here than over here, and this is one of our patients as an example. So this is some of the ways that we're going to be objectively testing for secondary endpoints in our study. Another disease that we looked at is multiple sclerosis. Now, if I tested MS patients that had the relapsing remitting form, we really wouldn't know whether our stem cells are doing anything. We would know whether they're safe, because this is a phase 1 safety trial, but we chose only the progressive forms. There's 2 forms of progressive, and that's secondary progressive and primary progressive. And we picked the progressive forms because they're the ones that have either already been relapsing remitting and now are on the steady downward slope downward, or they started that way, which is primary progressive. So these are the patients that have only a downward spiral, and which usually leads to death, and they're the ones that we chose. Really no treatment so far for the course of primary progressive MS. So we chose these patients to treat with the stem cells. Parkinson's disease. Yes, we're approved to do Parkinson's disease, but we haven't done any with true Parkinson's disease. We've only treated patients with what's called Parkinson's plus syndromes or Parkinson's-like syndromes. OPCD, olivopontocerebellar degeneration, Shy-Drager's disease, cerebellar ataxia, and in particular multiple system atrophy. These are Parkinson's-like syndromes, but they've never been actually diagnosed with Parkinson's disease because they're not Parkinson's disease. And we have a slew of medications for Parkinson's disease. We even have deep brain stimulation, which I implant for Parkinson's disease. Those are wires that go in the brain to treat Parkinson's disease. So we've only treated the Parkinson's plus patients where they have no recourse but to die within a few years of diagnosis. So I finally decided to go with this Ommaya reservoir phenomenon. I'm going to pull this out here so I can see what I'm showing, but this is the Ommaya reservoir, if you can see that. This is that exact picture. Let me turn it into the exact angle as the picture, and you can see that it's a small little reservoir, and the tube itself goes down into the brain, and it's implanted under the skin of the scalp. So it's invisible under the skin, and then this right angle brings the tube into the ventricular system. Let's do this. And the result of this, once we get this in, is that we can tap this on a regular basis. To put this in, we have to make one burr hole. It's smaller than a dime, and the incision is about 4 to 6 centimeters in length, and it's usually on the patient's right side of the skull. The drilling of this hole is routine work for a neurosurgeon. It's called a burr hole. We do thousands in a year. And then we pierce the dura a bit so that we could pass the ventricular catheter, which is also a procedure that's done by neurosurgeons probably hundreds of times a year, because we are tapping a ventricle to let out fluid for hydrocephalus or for other procedures. So that's the invasive part of this. And once that is in position, once the reservoir is in position, we can tap it with a syringe or a needle. You're all, if you're affiliates in the listening audience, you're familiar with the cell harvesting technique, which is a proprietary technique. And it's you know, absolutely a wonderful technique, but we are able to get about 50 cc's of fat from this technique, and as you know, we move from that to centrifugation, and we get what's called the stromal vascular fraction, which is the end of the centrifugation process, and then we draw up that aliquot of stromal vascular fraction, which, as you know, contains many other cells besides stem cells. It contains some pericytes and some fibroblasts and other cells that are in this aliquot here, but within it, we believe there are about 15% by our studies stem cells from mesenchymal source. One is from the hematopoietic source, and the other is directly from mesenchymal stem cells from adipose tissue. The safety paper has been submitted to the FDA showing the safety of doing this procedure and injecting it intravenously and intraarticularly in 1,524 patients. It has already been submitted. It's a wonderful paper which shows that the safety is almost bar none. So, injecting this into the reservoir, we felt safe. The IRB gave us approval. This is the way the reservoir is tapped. That's basically what it looks like. It's prepped with betadine. Everything's under sterile conditions. We are gloved and gowned. We draw off the CSF. We add SVF, and we flush with CSF. And the final outcome here is no change in the patient whatsoever. So they don't notice a thing when the cells are going in. The cells are, the amount of cells, the volume of cells that we put in is exactly the volume of CSF that we take out, including the flush. The volume of the cerebrospinal fluid in the brain is about 250 cc's, and so if you draw off 5 cc's or 10 cc's, the patient usually doesn't notice it at all. So we re-inject, and we've had no patients have any side effects on the day of injection. So when we're there injecting, it's as if we haven't even touched them. So it's extremely safe in that regard. I will tell you about some side effects when they get home afterwards, but let me show you what we presented at our national meeting for these first 20 patients in the first 2 years. So this is what was presented at the International Society for Cellular Therapy meeting in Memphis and at the meeting in San Diego. Our median age of the patients, the first 20, was 66. 3 of these patients had already had implanted a ventriculoperitoneal shunt. Now, a lot of patients with Alzheimer's disease can get shunts if their ventricles are very large. So now the shunt is already in, we can use that port to inject the cells. 17 of them got the Ommaya reservoir. In May 22nd, 2014, our first patient was injected. So the beauty of what I'm showing you today is that we didn't start this yesterday, and this wasn't just begun. We have now, on May 22nd will be our 3-year follow-up. And we've injected, as I told you, now up 31 patients, and I'll give you their results, but these results were what was presented at the meeting. We looked for secondary endpoints, and as any phase 1 study would, yes, we're looking for safety, but we're also looking for phase 1 results of safety in addition to secondary endpoints. And secondary endpoints differ for each disease. So what we looked at for ALS, for example, was just stabilization or improvement in their condition. For Alzheimer's disease and dementias, we looked at cognitive scoring. We looked at something called the NeuroQuant MRI and the CSF samples that I described to you before. With the multiple sclerosis progressive patients, we looked at the expanded disability status scale, which is the #1 scale that people look at to rate the degree of severity of the multiple sclerosis. And then for the single traumatic brain injury patient, the stroke patients, and the MSA patients, we look for any type of stabilization or improvement. Over the 2 years, for the first 20 patients, we gave 69 total injections in 20 patients. 17 patients had at least 2 injections, 20 patients had at least 1 injection, and 14 had at least 3 injections, so a number of injections in the first 2 years. And these are the number of cells, and you can see how they vary per patient, but our median was 6 times 10 to the 6, or 6 million cells per patient. And as you know, 15% of these represent actual stem cells, and half of those, or 7 or 8%, represent actual adipose stem cells by our analyses. The various volumes that were injected were 3.5 to 10 cc's, and our median was 4 cc's. So not a large volume. So I told you, have analyzed what percentage of the cells that are in this CSF, this SVF, stromal vascular fraction aliquot, are actual adipose-derived stem cells. And in our in Vitrogen count test that we used, system FACS analyzed, we found that 8.3% were adipose-derived stem cells. So our patients were getting approximately 1 million stem cells per injection. So that brings us to our later results, which is now adding a year onto what I presented at the various meetings. And now we're up to the nearly 3-year follow-up in 31 patients. So let's look at our results for the 31 patients just for the implantation of the Ommaya reservoir. So Of the 31 patients, they either had the Ommaya reservoir or 3 of them had shunts already implanted. We've had no infections. 1 was removed for sepsis from an infected G-tube, and this is just for the Ommaya procedure. So I'm not talking about the injection procedures, which I'll show you on the next slide. So for our surgical procedure of putting in the Ommaya, we've had no infections. A couple of patients had headaches after their surgeries, no fever. A couple of patients described some neck stiffness afterwards, but did not lead to infection. And 1 of our patients had a shunt malfunction, Ommaya malfunction, where the Ommaya stopped working after a while. And we can get that when the ventricles are too close together. So in that patient, we actually reimplanted the Ommaya reservoir. So that was a redo for that patient. As far as injections of the SVF, we've done 111 over the 3-year period, nearly 3-year period, in 31 patients. Our infection rate was 1 out of 111, and that patient had to have antibiotics and the Ommaya reservoir removed, and the Ommaya reservoir was put back in at their request because they wanted to continue. So out of 111 injections, we have a 0.9% infection rate. 7.2% after the injections of the SVF said, I got a little headache afterwards, and that usually lasted for a day, day and a half, and was managed by Tylenol. Fever. We had a few patients that actually got febrile after the injections, and believe me, in our first injected patients, we were very concerned about this being infection or something else, but it follows precisely what happens with subarachnoid hemorrhage and subarachnoid bleeding in humans. They get fevers also, and it's neurogenic. It's a reaction of the brain skull base or the p arachnoid to the blood products, where they can get a mild fever afterwards, and that also dissipated after 2 days and was resolved without any therapies. And the signs of meningismus, and I'm not talking meningitis, I'm talking meningismus, that's where you have neck stiffness and mild headache. We saw that in about 4.5%. It was usually dissipated by about 2 days. 1 patient did have a heart attack afterwards. He had already had 3 stents placed prior to this, and we felt this was unrelated to the treatment. As far as secondary endpoints, we were very surprised and very excited. So remember what we were doing. We were doing a phase 1 study. No real clinical evidence was being gathered, but we did look at secondary endpoints. And the secondary endpoints in the Alzheimer's population was extremely impressive, and I'm going to show you some of those in a minute. We've injected 11 patients so far with Alzheimer's disease or a frontotemporal dementia or other form of dementia. 3 patients have actually improved, and this is over a 2-3 year follow-up. 7 have been stable, and 1 was worse, and he was doing well until he stopped his own therapy. Multiple sclerosis progressive patients also did extremely well. 3 patients have improved and 3 are stable. The ALS patients we have not done very well with. 5 patients, 4 have died of their progressive disease. It's just a horrible disease, and 1 has remained stable so far. This particular patient is a physician himself. He's a doctor. Traumatic brain injury, we've seen improvement in that. 1 patient, a stroke patient, has been stable, and the multiple system atrophy, 2 are deceased, 1 is stable, and the rest are stable. I should say the rest are stable. Spinal cord injury patient, we've treated 1, and that's been stable. So we also looked at some MRI follow-ups in our patients, and the median follow-up has been 1 year after implant. We're looking to see if there's any abnormality from the cells. Is there growth, abnormal growth? Is there tumor growth? Is there any change in, for example, a multiple sclerosis patient's plaques? Have the plaques disappeared? Have they gotten better over time? So we've looked at 12 out of 20 so far, and we've seen no change in normal brain anatomy. And I'm going to show you a patient that has had the stem cells, probably one of the longest of all, who's had the stem cells, who has multiple sclerosis progressive. So let's look at her when she came in. This is our progressive MS patient. As you can see, she can only take one step about 1 inch at a time. And she traveled 4 feet in 1 minute. It took her 1 minute to travel the length of your desk. So this is 2 months after her first injection of SVF, and already she's beginning to mobilize, and she's made it 12 feet in 1 minute. 11 months, almost a year after her injection into the Ommaya, she's really beginning to walk much more improved. Her EDSS score has already gone up significantly, and look at her dorsiflexing her ankles and actually using her feet. She went 20 feet in 1 minute. And now this is a 2-year follow-up. I'm going to be doing her 3-year follow-up shortly. And look at her dorsiflexing and moving, and she could actually walk rather indefinitely. And she had no other therapies other than the SVF injected through an Ommaya reservoir. So a very positive secondary endpoint was reached in this patient. Let's look at another patient. Alzheimer's disease. We have a test that we can do. It's an MRI, and it's called the NeuroQuant volumetric MRI. And what we actually can do with this is a computer, it's not human, but a computer algorithm can measure the volume, the size of the human hippocampus. So this is the hippocampus here, this olive-colored area, and we can actually see the size of this, measure it on MRI, and then compare someone's hippocampal volume to an age-matched control without the disease. So, for example, if you're 75 years old, we do this. We compare the size of your hippocampus to that of a normal 75-year-old without Alzheimer's disease. And we can put you in a quantile, in a percentile, kind of like the SATs or the ACTs. You know, you're in the 85th percentile in math intelligence. Well, this is a quantile, a percentile that puts the size of your shrinking hippocampus, if you have Alzheimer's disease, into perspective of your age-matched peers. And in this particular patient, his hippocampal volume was less than 5th percentile. So in other words, he was 2 standard deviations of the mean away from the norm. A year after his stem cells, this is 2 years after his first quantile volumetric MRI, but 1 year after his first injection of stem cells, and he, I believe, it had gotten about 6 injections. We like to do them every 2 months. Was now in the 27th percentile for hippocampal volume compared to his age-matched peers. When I saw this, I was extremely excited, but it's not that much different from 5th percentile, and it could be some error. There could be some other factors involved. However, we just did this same patient in January of this year, and his hippocampal volume was up to 48th percentile, which is, as you can tell, from being in the 5th percentile with active Alzheimer's disease 4 years or 3.5 years earlier, to be now with a larger sized hippocampus and to be stable clinically, which he was, with some measures that actually have improved of his cognitive performance. Now he's average. He's in the mean. He's in the middle of his age bracket for his hippocampal volume. Are the stem cells repopulating his hippocampus? Are the stem cells that we're injecting decreasing the inflammation so he has less cell death, meaning his hippocampus may be the same size, but compared to his age-matched people whose hippocampus keeps declining, his has remained stable? Remains to be seen, but it's an exciting prospect. So we are hoping to study that more. Okay, so now let's remember, this is another secondary endpoint that we were looking for, is CSF analysis. Remember what I told you about the tau and the ATI, the amyloid total tau index, the phospho-tau. Remember, if you're way out here, that's very bad. If you're in here, you're doing very well. Well, here's this patient in April of 2016. We drew his CSF off before he had any stem cell injection through the Ommaya reservoir. So this was where he was at, pretty much off the graph. And here he is 4 months later, after 2 injections. We tested his CSF, and it's not as far out, and it's moving. But again, we pause. Is this real, or is it just kind of a sampling error? But his phospho-tau levels definitely decreased, and his ATI actually increased. So then, 4 months after that, in January of this year, so after 4 injections of stem cells, he's really moving. So he went from right off the scale, right there, to moving more. And we are hoping that as he keeps getting injections, this will actually normalize, and his cell death criteria, the beta amyloid, phospho-tau, total tau, will start improving. And it's really not that out of the question that the stem cells do stimulate neuron growth, because in lower forms of life and in humans, we all have stem cells in our brains. I don't know whether people know that. I think everybody in my generation was told that neurons never reproduce. They can't multiply. It's basically true. But can they be fixed by other cells? And the answer now is yes. And certainly we've done research in lower forms of life where in the rat brain, this by the way is a rat brain, in the rat brain, the stem cells from the periventricular zone or the subventricular zone can actually be turned on and mobilize and physically move to areas of damage of the olfactory bulb. So you know how important the olfaction is to a rat. That's how they survive and live. Well, this is the olfactory bulb of a rat that's been damaged, and the cells actually respond to that damage and move in to replenish the olfactory cells. Fascinating. We have that. Here's a human brain right here, and right along the edge of the ventricle is something called the subventricular zone. Well, wouldn't it be great if we could stimulate those cells to actually find areas of damage? Wouldn't it be great if the cells that we injected found the areas of damage and repaired them? Wouldn't it be great if the cells that we injected actually decreased the inflammation so that the damage isn't done in the first place? All of this remains to be seen with phase 2 and phase 3 studies, very simply. So what we have done is we have created a phase 1 study which is extremely valuable for the scientific community, where we've injected these cells through a reproducible port that is not painful to the patient at all to inject, and to very successfully get these cells into the brain on numerous repeated attempts, and to create an environment where we can actually get a patient treated over a long period of time to see whether the temporal nature of treating them is important. It never made sense to me that treating a patient with a single injection of stem cells is going to work. I mean, that's a pipe dream. That to me is a wonderful concept. I mean, these people who travel to Mexico or they travel to Russia to get their single injection of fetal-derived stem cells, which they have no idea where it came from, to have injected into their brain on a single treatment, to me is not really getting as much as they could for it. But their work remains to be seen, just like ours does, and I'm very open to that as well. We can't do anything like that here in the USA without the FDA's clearance for that. The work that we're doing is, in my opinion, the very first step of any work in the brain or in the body for that matter, IV or intra-articular, where you're taking the patient's own cells, you're not genetically modifying them, so they are not changed in any way, and you put them into the brain on the exact same day that they're harvested, an hour after they're harvested, so that, and in such a fashion that they're barely exposed to even air. So if one were to move forward with stem cell work in the brain, this is clearly the first and safest route to do it, as long as it's been in an IRB approved environment. And right now I have a grant application into the Alzheimer's Association, the national chapter, literally sent it in today, or it was sent in last week for the study. They are granting $700,000 for a novel translational research protocol, and we are hoping to be one of them, so that actually patients can do this for free, and even indigent patients and other patients can be included in this study. So let me give you the final summary of what I just described to you, which is truly landmark stuff, never been done in the world, and will hopefully pave the way for our future work with stem cells in the brain. The adipose-derived stromal vascular fraction was safely injected into the brain ventricular system. No patient had any complication worse than a transient headache and fever, except for the one patient that had an infected reservoir which had to be replaced, and that was 1 out of 111 patients. Secondary endpoints were particularly impressive with the multiple sclerosis progressive patients, especially the video that I showed you of the patient going from taking 1-inch steps at a time to actual dorsiflexion of the ankle and walking with an actual stride and gait, and to the Alzheimer's patients. Both of those showed extreme promise, and going forward, I think we're going to focus on these two disease entities. Disease stability or improvement was seen in 94% of the multiple sclerosis progressive and Alzheimer's population patients combined. So a very high number of stability and improvement in those two groups. No patient had any demonstrable MRI changes except for the better in that patient that had the quantitative analysis done of his hippocampus. This procedure is very simple. No genetic modification is done. We're not using fetal tissue, embryonic tissue, genetically modified tissue, altered tissue in any way. And it is obviously worthy of a phase 2 trial. Cell banking and propagation could add an advantage in the future. Thank you very much. I guess we'll take questions at this point. And I have questions that have been brought to me, and I will address those right now. So, of the questions I've received, one of the questions is, what is stopping all of us from injecting stem cells directly into the brain to heal Parkinson's disease? So I want to reiterate what I said in my talk. Parkinson's disease has great treatments right now. It's the Parkinson's-like diseases that we treated in our system that are the ones that have absolutely no treatment, and they have no recourse, but death at the end of their disease process. So nothing is stopping anybody from injecting cells into the brain for Parkinson's disease. We are not doing it here. We're doing it for the patients with the advanced forms and different forms of Parkinson's disease. I definitely see the future. The future is there, and the question is whether they should be stereotactically implanted into certain areas of the brain directly, or bathed in the brain like with the Ommaya reservoir. But other diseases like Alzheimer's disease and MS, which are whole brain diseases, would be more amenable to that. As you know, in Parkinson's disease, the problem is in the subthalamic, substantia nigra, not producing dopamine. Let's see. Is this a viable option for Alzheimer's patients right now today? The answer is yes. We are still enrolling patients in the phase 1. I call this a phase 1/2 now because we're still observing safety, but now we're focusing more on the disease entities of Alzheimer's disease and multiple sclerosis. And the answer is yes. We can enroll in any Alzheimer's patients right now. I make a pact with the neurologist who sends them to me that they're going to follow them clinically, and that we are going to look at all the parameters like we discussed, the CSF analysis, the MRI, quantitative MRI scans, etc. So it is a viable option, especially for a disease that has absolutely no disease-altering medications at this point. Okay. Alzheimer's runs in our family. What is the best thing I can do to avoid this disease? Well, I think the best thing to do is to live a healthy lifestyle. I think you can get yourself tested for it. There's a gene that you can look for. It's the APOE gene, and if you have the APOE3 gene with a 4 as another allele, you've got a increased risk of getting Alzheimer's disease, and you probably got it from one of your first-degree relatives. If you have APOE4 and an APOE4, it's almost inevitable. So there are things you can do to be proactively knowing that it's coming, and then to decrease things like alcohol intake, neurotoxins, mercury levels, watch how much sushi you eat for your mercury levels, things like that that you can do. But certainly get analyzed quickly by your nearest cognitive and neurology specialist, and then you can move forward with management and prevention. Can we get similar brain results with IV administration of stem cells? So, yes, putting a reservoir in is a little aggressive. But remember what we're doing it for. We're doing it for patients that have no hope. IV forms of the stem cells, is fantastic. I mean, we use IV forms for a number of diseases with some superb results. The studies that are coming out now with IV injection for multiple sclerosis, for other disease entities, is showing improvement in a lot of patients. So if you want to move into the more aggressive phase of treatment of something like Alzheimer's disease, you certainly can consider the Ommaya reservoir intrathecal form. But as a beginning, as a start, one might consider using the intravenous form of the stromal vascular fraction as the least invasive form. For example, my colleague Sean Berman is doing work with traumatic brain injury in football players or athletes that get brain injury, and he's got a rat brain injury model. And he's finding that by IV injection of the stem cells, it's actually repairing damaged brain. But that is freshly damaged brain from the outside. So the blood-brain barrier is probably opened by that damage, allowing anything in the bloodstream to get into the brain and help repair. How about a patient whose blood-brain barrier is intact, like a Alzheimer's patient or like an ALS patient? I don't know whether we're going to get the same effect from an IV injection than you will with an intrathecal direct intracerebroventricular injection. We are working on the cost. Okay, so these are patient-funded research, and it's widely accepted and very, very well respected to allow an IRB protocol to be funded by patients. It's also funded by philanthropy. And I already mentioned the philanthropy of the possible grant from the Alzheimer's Association for our work with Alzheimer's disease. That would be fantastic. Perhaps, well, I don't want to say, but if you could perhaps plea for donations, we could have a study that is fully funded. Big pharmaceutical companies are what universities usually look for funding. Well, unfortunately, there's really no financial advantage to using a non-genetically modified cell. So a big pharmaceutical company is not interested in this type of work, which is rather unfortunate, because this type of work may go unfunded and undone, not done, when it probably should be the very first thing that's done in the world of stem cell work. So every university and other major centers that are doing stem cell work have been using genetically modified cells and are usually sponsored by a pharmaceutical company to see whether that exact stem cell is doing a service to the patient that actually can become one day a pharmaceutical. So the work we're doing, rather unfortunately, does not have any financial gain to it for a pharmaceutical company. So we could only get our money through either patient-funded research or donations. And we're looking for grants and government grants and other grants. So that's what we're looking for, and we'd be delighted to entertain any grants or philanthropy you'd like to put toward this work. Let's see. So another patient, a patient actually sent a question in. I was diagnosed with MS in 1995. I am now 56 years old. It has progressed to secondary progressive MS. So what I described to you earlier as MS being a relapsing remitting, they probably had the relapsing remitting form, and now they're secondarily progressive where it's completely downhill. For that patient, unfortunately, the course is usually downhill, progressive, and death is the end point. For that disease, there are no FDA-approved medications for it. So, in my opinion, yes, you are a great candidate for intracerebroventricular injection of SVF, and it's something that you may want to look into, depending on your disability. So I think we've gone close to a good hour here, and I hope you have enjoyed this. I have a website that you can certainly look at, cduma.com. It's rather easy. That's my first initial and last name, and that is a phone number you can call for any clinical information if you wish to get that. And I thank you very much for spending this hour with me here on a Friday afternoon, and it has been a pleasure being with you, and thank you very much.